All right, let's go ahead and get started. Good morning, everyone. Thank you for joining us. I'm Corinne Highland. I'm the Public Information Officer for Santa Cruz County Public Health, and I'll be moderating today's Clinicians Resource Call. The purpose of this meeting is to support Santa Cruz County clinicians in the evaluation and clinical management of patients and provide updates on public health trends. Public Health hosts these calls, well, monthly, although I think we're going to take August off, Tuesdays at 7:30 a.m. We ask as we move through the call that you submit your questions via the Q&A function rather than the chat, and we'll do our best to address all your questions. And we'll send out the slides and all the resources in the next day or so. Um, Today, we are going to have an back to school immunization reminder from our Deputy Health Officer, Dr. Leclerc Cortez. Then we are going to have a presentation on SIDS from our MCAH team, and then we'll move to an update from our County Office of Education. So with that, I am going to go ahead and turn it over to Dr. Carissa Leclerc Cortez.
Thanks, Corinne, and thanks everybody who's here on the call today. I know that we're really thick in the middle of vacation season, so there's many people that are out of the office and kind of folks are holding down the fort. So we appreciate you all. I hope that if you have kiddos, you're able to spend some quality time with them before they head back to school, which seems like it always happens sooner than I expect. And I also am feeling grateful just thinking of us taking time off, the folks who are working so hard in the fields. I see farm workers in clinic, I see them driving through Watsonville, just really potentially at the risk of their own health, really working super hard. And those are the folks that are putting food on our tables. So I'm feeling very grateful for them and also recognizing a lot of the significant threats to the health of this part of our community. So with that, can we go to the next slide? Oh, next slide, please. Yes, perfect. So I am covering for someone today who is out sick on this presentation. So if it seems like I'm winging it, I appreciate your grace on this. Like I mentioned, as we think about kids shockingly already heading back to school, we wanted to just give some reminders because it's always a good time to think about immunizations. And so as kids head back to school, we wanted to direct you to a couple of different resources. Uh, We've linked them on the slides here. This website, Shots for Schools, has a lot of good information with up-to-date requirements for kids to enter school in California. We also wanted to reiterate, because I know that there's been a lot of federal changes and wanted to make sure that everyone's on the same page that California school and childcare requirements for vaccines are the same. There have been no changes from there. All vaccines that are recommended by CDPH continue to be covered by insurance in California. For patients that do have cause for a medical exemption for vaccines, the state has put together a really nice set of frequently asked questions because we know that this can be something that's quite complicated. So that's something that we've also linked as a resource on the slides here. Next slide. So just setting the landscape of where we're at in Santa Cruz County. Like we've mentioned previously, we unfortunately continue to perform well below the state level. So we are one of a handful, maybe 7 or 8 counties in the state that have fewer than 90% of kindergarten students who've met all of their vaccination requirements by the time that they're entering kindergarten. So definitely room for improvement here, and particularly in comparison to our Bay Area peers. Next slide. So breaking this down further, who are these students that are behind on their vaccines? So like I mentioned, for 2025-26, in Santa Cruz County, only 84.9% of kids that were entering TK or kindergarten had all of their required immunizations by the time that they started school. So the other bucket, a little over 1% of kids were conditional entrants, meaning that they were in the process of being caught up. 1% were overdue for vaccines. A very small fraction, 0.1%, had medical exemptions. And then the largest category is this other category. That's in green and is mostly made up of kids in independent study, plus a small fraction of kids who had an IEP. Next slide. So for providers, things to think about and some strategies that potentially can be helpful in increasing the fraction of kids who get their immunizations on time. The California Immunization Registry is really helpful to get a sense of where kids are at with their vaccination requirements. Many EHRs also have these reminders that can be helpful in identifying kids who've missed either their recommended immunizations or have missed well child visits. Hopefully, you have support at the systems and clinic level to reach out to kids to really try to bring in engagement for them. And things that can be helpful is using scripts that kind of have a pre-recorded message, sending out letters, or sending texts to families. Otherwise, things that can be extremely effective are having dedicated immunization catch-up clinics. And so planning specific times prior to the start of school and trying to be thoughtful about times that work for parents who work other jobs. So keeping times open on the weekends and potentially in the evenings as well. Next slide. So something that we wanted to talk about is the topic of vaccine hesitancy, because this is a not a new issue, but is certainly one that's very complex and has continued to worsen in recent years in really the shadow of the COVID pandemic, as well as social media allowing a lot of misinformation to be able to be spread. Understandably so, folks are also having less trust in institutions. So I think that in terms of building confidence in our families, we certainly have a lot of barriers to overcome here. Something that gets talked about a lot and I think is worth mentioning is this vaccine hesitancy. Many folks exist on a spectrum, ranging from folks who feel very staunchly that they're going to refuse all vaccines, all the way to folks who, maybe accept vaccines but aren't totally sure. There's some folks who might delay vaccines, might refuse some, but not be totally sure exactly why. And so, kind of that middle bucket is what we refer to as the movable middle. Folks who are not so solidly set in their anti-vaccine beliefs that they could be significantly impacted by providers continue to express curiosity, continuing to show empathy, and just repeatedly having thoughtful conversations about it. This is going to be, by and large, the portion of folks that you can have the most success in actually impacting rather than really trying to waste time and build frustration in folks who are very staunchly opposed to vaccines. Next slide. So, some other strategies, like we had talked about in addressing vaccine hesitancy. So, something that I think many of our clinics do, which is wonderful, is offering and giving immunizations at any visit. So, not just waiting for well child checkups, but anytime that folks come in for a sick visit, any type of acute care presentation, making sure that as long as they're well enough to get an immunization, that that's something that we're doing at that time frame. Like I also mentioned, if you're able at the systems and clinic level to open up a number of immunization only appointments, especially in the days and weeks leading up to school entry, this can be really helpful in getting those kids in who are just behind and really need to get their vaccinations before school. Otherwise, I'm sure that you all have experience with this, but just to reiterate sort of our communication strategies around vaccines, I think that's something that we talk about is using a presumptive approach. So stating it in a sense of something like, your child is due for 3 vaccines today, and presuming that the way that you communicate this, that the child is going to proceed and get their vaccinations, rather than kind of leaving it more open-ended. Being ready to answer questions and offering a strong recommendation, making sure that it's clear about your stance on this and that you are confident, kind in the way that you recommend it, but that there's no sort of waffling that you do. And that's often helpful in building trust with families. Next slide. So, some of the most common missteps when they look at it in the literature that lead to vaccines being missed. So, like I mentioned, the provider offering a recommendation is important. And a unfortunate way that we might miss this is just neglecting to make a recommendation at all. It can sort of be easy to do, especially because it avoids a potential conflict. But I think if we don't make recommendations, it can hamper patient trust and confidence in our medical care. An alternative, but still not great, is giving a weak recommendation. So, some type of vague language, for example, saying, this vaccine, sometimes we give it to people in your age group. It makes it seem like you're not totally sure of the evidence, or it makes it feel like it's something that's optional. And then all the way on the end of the spectrum is sort of a participatory recommendation that really frames it as a decision that the patient can make where both are good options, offering, would you like to get a flu shot today? That really makes it feel like it's optional and that we don't really feel strongly one way or the other, which of course is not the case. So I think trying to avoid any of these types of communication is something that's important. I myself am someone who's very conflict averse and I have a hard time having these more challenging conversations, but I think it's something important for us to push ourselves to do. Next slide. Uh, Lastly, as we talk about ways to increase immunization, just creating a culture at your clinic where immunization is standard. So, making sure that every patient and parent is aware of the immunization policy, making sure that information about vaccines is readily available, easy to understand, and easy to access. At every visit, making sure to review patients' vaccination status and making sure to schedule upcoming vaccines during those visits. Making sure to just give reminders, whether verbal or text, about upcoming vaccination appointments, and just making sure that everyone on your team is sharing a consistent message about vaccines. That all can be really helpful in increasing these rates. Next slide. And we've linked a ton of really helpful resources here. If you have any questions about vaccine schedules, resources for covering them, ways to have these difficult conversations, and a lot of different other useful resources. So I appreciate our immunization coordinator, Courtney Cantrell, who is the one who put these slides together. And thanks to the team for doing all the work behind the scenes on this. I will now pass it back to Corinne.
Thank you so much. I want to remind everybody that they can put any questions in the Q&A function and we'll do our best to answer them. Next, we're going to move on to our presentation on sudden infant death syndrome. Um, Rachel Van Cott, who is our SIDS program coordinator, will be providing that for us. I'll go ahead and turn it over to you, Rachel.
Thanks, Corinne. Hi, everybody. I am Rachel Van Cott. I'm a public health nurse here in Santa Cruz County, and I serve as the perinatal services coordinator and the SIDS program coordinator. Next slide, please. Okay, so here in our SIDS program, a large part of what we do is provide safe sleep and risk reduction trainings to organizations across the county. And we also respond to support families when an infant dies suddenly and unexpectedly. It's not mentioned on the slide, but I want to also say that we do maintain a SIDS website here at the county, and it is loaded with risk reduction strategies, grief support resources, videos, downloadable resources for families, caregivers, healthcare providers, and childcare providers. So I encourage you to check that out, and we will send that link out in the follow-up email. Next slide. Okay, so typically what happens when an infant dies suddenly and unexpectedly, somebody will call 911, EMS will respond, and then a decision will be made about CPR and transporting the infant. In Santa Cruz County, we always transport the infant to the hospital, and that's where it will be pronounced dead. And then after that, a coroner will arrive and begin their investigation. Next slide. Okay, you can see here the different roles described by the California Department of Health, Public Health. The coroner handles the investigation, the autopsy, and then they are also required to contact us within 24 hours. And then we have 3 days to contact the family or caregivers. And as SIDS coordinator, I respond and spend time with the family. I provide education, grief support, and other resources that they may need. Next slide. Okay, so just to start with this definition of sudden unexpected infant death, this is an umbrella term used to describe any sudden and unexpected death of a baby under 1 year of age where the cause is not immediately obvious prior to an investigation. And some possible causes of SUIDs are SIDS, sudden infant death syndrome, accidental suffocation and strangulation in bed, infections, trauma, either unintentional or non-accidental, poisonings, and overdoses. There are more, but these are just examples. Next slide, please. Okay, so this category of accidental suffocation or strangulation in bed occurs when something limits the baby's breathing. So ASSBs are responsible for 3/4 of all unintentional injury infant deaths. More than 85% of all ASSBs occur from birth to 6 months, with the most happening in the first 4 months. The first one is suffocation. We know what this is. Overlay is when another person who's surface sharing or is sharing a surface with an infant while sleeping rolls over on top of them. Wedging is a form of suffocation or mechanical asphyxiation in which the nose and mouth or the thorax are compressed or obstructed. And this happens when an infant is trapped between two objects, for example, like the wall and a bed, or the side of a chair, or between couch cushions. And then strangulation generally happens from loose bedding or other things in the crib that don't need to be there. And then positional asphyxia. This occurs when the baby's chin drops and closes off the airway. And this may happen in different types of sitting devices that people use, including car seats or hammocks, swings, those kinds of things. Next slide, please. Okay, so another type of SUID is SIDS, sudden infant death syndrome. So SIDS is a diagnosis of exclusion, and that means that SIDS is the cause of death when all other causes have been excluded. And this is why the autopsy and the investigation is so important. And I want to make the point that SIDS cannot be prevented or predicted, but we can reduce the risk. Next slide, please. Okay, so the triple risk model seen here is the most widely accepted conceptual framework to date in understanding SIDS. So there are three pieces here. First, all of these pieces have to be at play for a SIDS to occur. So the first is that there's some sort of intrinsic vulnerability. For example, an undetectable brain abnormality or a genetic mutation that impacts the part of the brain that controls breathing and heart rate. And we have no way to test this. We don't know that it's there, and we have no control over it. The second is that the infant is in a critical developmental period, most commonly the first 6 months of age when there's a lot of rapid growth and development happening. Again, we have no control over this. So the third is an outside stressor, like, for example, an unsafe sleep environment, exposure to secondhand smoke, or overheating. And we'll talk about these shortly. But I want to make the point that none of these factors alone are believed to cause SIDS, and but they may decrease a vulnerable infant's chance of survival. Most babies that encounter different environmental stressors are going to be able to overcome it. However, an already vulnerable infant may not. Next slide, please. Okay, so for several years, our national count has rested around 3,000 SUID deaths per year, but the numbers have begun to increase. In 2022, there were about 3,700, with about 1,500 deaths from SIDS, about 1,100 deaths from unknown cause, and about a little over 1,000 deaths from ASSBs. So just a note about this 31% of unknown. There's no standard reporting method among coroners, so the unknown portion of this graph, by definition, are likely SIDS. Next slide, please. Okay, so this graph just shows the uptick in both California and the United States. And I want to mention that we are also seeing an increase locally. Prior to 2024, we had not had a case since 2018. And we had one case in 2024, and we've had 3 cases here in Santa Cruz County in the last calendar year. I'm sorry, the last fiscal year. Okay. So it's important to note that there are significant racial disparities at play here. And as you can see here, the SUID rates are highest among non-Hispanic Black infants, Native Hawaiian and Pacific Islander infants, American Indian, Alaska Natives, and multiracial infants. Next slide, please. Okay, so the first and most important thing you can do to help reduce the incidence of SIDS in our community and across the board is familiarize yourself with the safe sleep guidelines put forth by the American Academy of Pediatrics. Every few years, the AAP releases updated guidelines, and the most recent were in 2022. These recommendations are based on over 500 studies and are outlined, that are all outlined in an accompanying technical report. You can find these guidelines and the technical report really easily. They're on our Santa Cruz County website, and you can also just do a Google search for that. The number one recommendation is to promote the ABCs of sleep. Babies are safest when they are alone on their backs in an empty crib or pack and play with a flat, firm surface. A single fitted sheet is all the bedding that should be used. Other guidelines not listed on this slide include room sharing rather than bed sharing, avoiding any type of surface sharing during sleep, especially sofas and armchairs. They're the most dangerous. Avoid routine sleeps and sitting devices like car seats, strollers, and swings. And then using alternative sleep surfaces such as hammocks, the baby tents, sleep positioners, and other incline products that are not recommended. And using commercial home monitors during sleep is discouraged. Next slide, please. Okay, so here are a few other risk reduction strategies. The first one is human milk. We know that this is associated with a reduced risk of SIDS, and the protective factor increases with exclusivity, the longer the duration. So any is better than none. So just keeping that in mind, I know we're all supporting breastfeeding as best we can. Pacifiers. So this mechanism is unclear, but there are a lot of studies that report a protective effect of using pacifiers and reducing the risk of SIDS. One of the things I find really interesting about this is that if it falls out, even in just the first few minutes that the baby is asleep, you do not need to reinsert it and you're still getting that protective factor. Okay, avoid harmful substances before, during, and after pregnancy. Regular perinatal and infant checkups are really important, and there's no evidence that there is a causal relationship between immunizations and SIDS. Avoid overbundling, covering the head and face. No extra bedding is needed or necessary in the crib. Dressing infants appropriate for their environment is important. No more than one layer, more than an adult would wear. No hats indoors unless it's the first hours of life or the infant is in the NICU. And then it's really easy to evaluate for sweating, flushed skin, and the chest feeling hot to the touch. And that's how you'll know that a baby may be overheating. Swaddling. Swaddling, there's really not really solid guidance around swaddling, but they do recommend that after the first 3 to 4 months, not to swaddle any longer once the infant begins to attempt to roll over. And then tummy time. Tummy time helps infants develop strong muscles in their necks and their backs and their arms and shoulders. And this could really help them get out of unsafe sleep positions. And the goal for tummy time is to start slowly upon discharge and gradually build to 15 to 30 minutes a day by the age of 7 months. This is also a great bonding opportunity. Next slide, please. Thank you. So what can you do? Become an ambassador by sharing this information, teaching the ABCs of safe sleep, babies alone on their backs in uncluttered cribs, on safe sleep surfaces is so important. That is just the number one thing that you can do. Holding family-centered safe sleep conversations with your patients and including anybody you have access to, anybody that comes into the office, if you're a home visitor, including anybody you have access to, grandparents, aunts and uncles, older siblings that may be helping to care for the infants, any neighbors or babysitters. It's just really important that everybody is on the same page. And just meeting your patients with curiosity, open-ended questions, and a shared focus of goals. Recognizing, that a lot of people from different cultures and different generations have really different perspectives on infant care and what is safe and acceptable. For those of you trained in motivational interviewing, these techniques are really useful in this situation. And then always using clear and consistent non-judgmental messaging. And train up your staff. Make sure that your staff is well trained in pro-safe sleep behaviors. This is really, really easy to do because you can reach out to me and I would be more than happy to come train your staff. And then modeling, parents pay attention to everything healthcare and care providers do. So please don't underestimate how much trust they have in you and be sure to model the best practice behavior. Next slide, please. Okay, so if your organization would like more thorough training, please contact me directly. My email will go out in the follow-up email. We'll be sending out some resources as well. Visit our website. We also have a maternal, child, and adolescent health newsletter. If you're interested in receiving that, you can email me directly and I can get you on our distribution list. And finally, if this is a topic that interests you, save the date for our annual California SIDS conference this October. The Education Day will be on October 15th, and this year it will be held in person in nearby San Jose, which is really rare. So it's a great opportunity. Thank you so much for your time, and I'm going to go ahead and send it back to Corinne.
Thank you so much. That was some useful information. Again, I want to remind everybody any questions they might have to use the Q&A function. And so with school coming up here in August, approaching quickly, we're so grateful to have Dr. Ferris Sabah with us, our County Office of Education Superintendent. I'll pass it over to you.
Thanks so much. Good morning, everybody, and thanks for the opportunity to share a brief school update. Can we get to the next slide, please? There have been several important new laws that go into effect this year, starting July 1, and together they reflect a broader focus on student wellness and safety and access to care. AB 3216 requires every school district to adopt a policy limiting smartphones during the school day. We recognize how impactful smartphones have been and harmful in many ways for our students. And every district has now implemented a policy to limit the use of smartphones during the school day. Now, there are different varieties of how this is being implemented, everything from taking phones away once students come into the classroom to just asking students not to bring out their smartphones during the day. But that the requirement to have a phone-free school is something that is being implemented across California. SB 389 expands access to specialized physical health care services by allowing licensed vocational nurses under the supervision of a credentialed school nurse to provide certain services to students. And AB 727 requires student ID cards from grades 7 through 10 to include suicide prevention resources. And then finally, AB 1264. This is a law to phase out certain ultra-processed ingredients from schools and reinforcing California's commitment to healthier nutrition for students. So taken together, these new laws really attempt to reinforce schools not only as places of learning, but that they're critical environments that promote students' physical health, mental health, safety, and overall well-being. Let's go to the next slide, please. We wanted to share several resources that can help support students with disabilities or students who may have suspected disabilities and needed additional evaluation. And so we put together a folder for clinicians. You could get to it by going to sccoe.link/IEP info, and I'll put the link in the chat for you. And included is a folder with a few resources. One of those is, for example, to understand how the special education process works in schools. We want to be able to partner for clinicians to be able to partner with schools and families. And in this folder, you'll find guides to understanding the difference between an individualized education plan or IEP, a 504 plan, and the student success team or student study team process. This is the way that our schools evaluate the needs of students and determine what the best educational plan is for them. And so we've also included contact information for special education departments in each of our school districts, and information about the rules and services for children under age of 6, which are different and a little bit more complicated than for students who are school age, and a sample letter that families can use to request special education evaluation that you can help families with. Our goal really is to strengthen the partnership between schools and families and healthcare providers. And because working together, we're able to identify the students' needs early and coordinate our efforts and ensure that students receive the supports and services they need to be successful both in school and in life, of course. Let's go to the next slide, please. So this is an example of what is included in there, which is kind of a breakdown of what a student support team or student study team process works, and how we bring people together to evaluate the needs of students, what a 504 plan is, and what an IEP plan, individualized education plan, looks like. And so we encourage you to check out these resources. Again, I'll put them in the link in the slide in the comment section, so that you'd be able to check them out, and please reach out to me if you have any questions. And that concludes my report. Back to you, Corinne.
Thank you so much. We do have a question in the Q&A. For phones in schools, are schools in general also accounting for medical need for smartphones? Dr. Lavelle says, I've had issues with schools in the past for my T1DM pediatric patients who need their phones for CGM monitoring.
Yeah, so
Glucose
there are
monitoring.
exceptions for students that have one of the requirements of the law is that phones have to be made available for students for emergency situations or medical needs. And so there absolutely is an exception. I would say that this is the kind of thing that a notification to the school that shows that there is a medical need for students to have their phone, and absolutely schools will need to honor that.
Thank you. And then I thought this question might come up today. It's also in the Q&A. Any information on cyclospora parasite outbreak? Are there any cases in California? And yes, we do have some cases in California, but we currently do not have any cases that we know of reported in Santa Cruz County. So just to answer that question as well. Let's see, I think that is all our questions in the Q&A. And then, yes, there are the link to the resources that Dr. Sabaj has put. If there are no other questions, I think we'll go ahead and end a few minutes early today. I want to thank everybody for participating. I hope that the rest of your summer goes well. Our next clinicians resource call will be September 8th. We are going to go ahead and skip August. So I hope, yeah, take care and have a great day.